This lesson is going to be about the post-operative complications. You're going to see as a differential, these things are covered in much more detail in other lessons. So I'm going to hone in on the stuff that you should really consider when you see post-op day something and then this complaint. So this is going to be much more useful for the test than it is for life, but it will give you a quick differential for when you want to impress your attending on rounds. Let's go through each condition one at a time. The first one is going to be post-operative chest pain. And what you're doing with chest pain is deciding, is this person having chest pain because of an MI, a PE, or something else? Because these are the things that are going to kill you. And most of the time, patients who are having chest pain post-operatively do not have these diseases. But inpatient suddenly develops chest pain, got to figure that out. So for the MI, you're going to get an EKG looking for 12 lead changes, and you're going to get troponins. For pulmonary embolism, you might get the ultrasound of the lower extremities looking for the DVT, or a spiral CT scan. In the evaluation of chest pain, you might do a lot more than that. So it's not going to be, oh, what should you do if chest pain? It's going to be, what should you do if chest pain and risk factors? Because other things like pneumothorax may still occur, but you're not looking for those right off the bat. If they're having a myocardial infarction, and this is why you did the pre-op clearance, was to avoid this, well, then you need to treat them like they're having an MI. And that's going to be with percutaneous coronary intervention right away if there's a STEMI, or heparin, generally in the way of low molecular weight heparin full dose if the troponins are elevated. So there's a STEMI and STEMI. And not that we do it that much anymore, but just so it's said, they just had surgery. You cannot use TPA. The only thing you're going to be able to do is get a cath. If you find a pulmonary embolism, you're going to do heparin, bridge to warfarin. They like asking this question because they want you to remember you need to bridge to warfarin because it is initially hypercoagulable. All right, that's chest pain. The other thing you're going to get a weird differential on is altered mental status. You have to remember, we control everything. So the things that are on the differential for altered mental status outside the hospital really don't bear weight when you're considering someone who's post-op. We generally are the cause. For example, you might have issues with electrolytes. And the electrolytes that are going to cause the most problems in the way of altered mental status are going to be sodium and calcium. And generally, with hypercalcemia and hypernatremia, you don't have enough volume or you don't have enough free water, simply give it back. If you want to find out if it's the sodium or the calcium, all you have to do is get a BMP, a Chem 7. You're going to be doing that anyway. Another cause of altered mental status, especially in the elderly population, people who are coming in getting anesthesia, who might have a little bit of Alzheimer's dementia, who get really bad at night, that's called sundowning. And sundowning is expected of the elderly. Elderly patients do get surgeries, and surgeries are a huge metabolic drain. And so if you see sundowning, you're just going to treat with atypical antipsychotics. Reorient them and get them out of the hospital, otherwise they're going to get into trouble. But along with altered mental status, you might find hypoxemia. We've talked about some of these diseases already, things like a pulmonary embolism, pneumonia, or atelectasis, but really where the test is going to go, if they're talking about altered mental status post-op, is ARDS. ARDS, what you want to remember is that you have to have a tumultuous course, prolonged intubation, lots of fluids, lots of transfusions, the belly's left open because you can't close because it's so edematous, and they're hypoxemic. That person's going to need PEEP and oxygen support, which is going to come in the way of an intubation. Not common, but something to look out for on the test. Where you might actually be able to save someone's life, and this is probably going to be on your test, is DTs. delirium tremens, alcohol withdrawal. You ask your patients in your H&P, hey, drink alcohol? And they say, yeah, drink at night. Well, the person who drinks more than that, who suddenly has all alcohol cut off, is at risk for going through alcohol withdrawal. And the way it's going to work is this. They come in the first day having been NPO and they get operated on. No big deal. Next day they're fine. They might, though, begin to develop some hypertension and tachycardia. And rightfully so, you'll see hypertension and tachycardia as postoperative pain. So you increase your pain meds. That doesn't work. And then they're going to get sweaty and they're going to start to shake. If you catch them here, you can prevent the seizures. Because 48 to 72 hours later, and this is the postoperative period, right? 48 to 72 hours after the surgery, they get hypertensive, tachycardic, sweaty, and start to tremble. They're on their way to full seizures. So if you get them at altered mental status, they're going to have these things, and they're at the point of seizing, so give them benzos. Abort delirium tremens with benzodiazepines and save somebody's life. Moving on, talking about decreased urinary output. This is a big one in the postoperative period. Normal is 0.5 cc's per kg per hour. And if you have less than that, something's wrong, because most of your pre-op clearance goes into evaluating these things, and generally, people have good kidneys when they go to surgery. So it makes sense that they have good kidneys coming out. The first thing you want to do is ask, is there the urge to void? What you're asking is the bladder full? If the answer is yes, that means they have some sort of obstructive picture. And you can evaluate this obstruction with a bladder scan or simply doing an in and out cath. Cut on someone's belly, it takes a while for their organs to come back online. It's effectively a neurogenic bladder, not a big deal. But you coax these patients into peeing on their own spontaneously by saying, if you can't pee, you're getting a cath again. And remember, Foley catheters cause UTIs, so do an in and out cath only, or you might use a bladder scan. And that's a nursing assessment tool that tells you how much urine is in the bladder. But if there's no urge to urinate, it means they really do have nothing in their bladder. And it might be renal failure. The next thing you do is look at the urinary output. Is there any output at all? Because for someone to go from making urine to making no urine, from having some GFR to absolutely zero, it's really rare. So if they have no output at all, this is probably mechanical in the way of a kinked Foley. Simple test, simply unkink the Foley and watch all the urine come out. Or irrigate it to clear any blockages. But if they have some output, just not a lot, now you're looking at actual renal disease. And you have to decide, is it intrinsic or is it prerenal? To do that, you just give them some fluid. You do a 500 cc bolus as a challenge. The idea being that we are controlling their intake and output. We made them NPO. We cut them open and had insensible water losses. Is there decreased urinary output simply because we haven't given them enough fluid? Well, the way you answer that question is by giving them fluid and seeing what happens. If the urinary output picks up, they were volume down, and the only thing they need is some more fluid. If they don't, though, now you're talking about intrinsic renal disease, and this is best left up to the medicine videos. But the idea is going to be that you have to have some really big hit or some allergic reaction to medications in order to get intrinsic renal disease. So this is not going to be the surgery question. This is going to be for medicine. And if you've already watched the medicine videos on renal failure, you realize that it's backwards, right? You ruled out post-obstructive uropathy first before deciding between pre-renal and intrinsic renal disease. And in the post-operative period, it's almost always going to be too little fluid rather than too much. The last one on the fun half of this is going to be what happens when there's abdominal distension. This is useful in the postoperative period, but also in the patient who presents with abdominal distension who's not post-op. What you want to be able to compare is someone who has an ileus, against someone who has an obstruction, against someone who has Ogilvy's, the distractor for these conditions. An ileus is functional. You just cut on their belly. It takes a while for things to get going. The patient is going to present at day 1 or 2, and there'll be no stool and no flatus. That's why you ask your patients every day, have you pooped and have you passed gas? You're going to diagnose an ileus by getting a KUB, flat and erect. And what you're going to see is because it's functional, it's metabolic, the entire bowel is affected. Ileus if whole bowel affected. What you're going to see is a small bowel be dilated and the large bowel be dilated all at the same time. The treatment for this is going to be fluids, potassium, and getting them to move. If they move, their bowels will move. So if you have trouble with post-op ileus, make sure they're staying hydrated, given potassium, and moving around. Now compare that KUB to the obstruction. We talk more about this later on in this course. The path is going to be that, obstruction. And this is the person you suspect has an ileus, but by day 5, they still have had no stool and no gas. Diagnosis is made the same way. You get an upright, erect KUB, and you'll see one of two things. You'll either see a small bowel obstruction or a large bowel obstruction. And the idea here is that if you're obstructed, nothing can get by the obstruction point. But everything after the obstruction has no problem getting out. So what you're going to see in a small bowel obstruction is the entire bowel completely decompressed. So you won't really see that much gas pattern. There won't be gas in the colon. At the obstruction, nothing gets past it. So you'll see dilation proximal. If you have a large bowel obstruction, same thing. Large bowel is going to decompress distal to the obstruction, and the proximal area is going to be distended. But because you have an ileocecal valve, small bowel is going to be normal. This is a small bowel obstruction. This is a large bowel obstruction. We're going to talk more about this in that later video, but I want you to see as conservative measures will be an NG tube, but ultimately because it is an obstruction, you're going to have to go to surgery again to undo the damage. And the obstruction generally is going to be adhesions post-op. And you have to compare these all against Ogilvy's syndrome. And Ogilvy's syndrome is a distractor because it is also functional, but it impacts only the colon and the elderly. It is a functional ileus of the elderly colon. You're going to diagnose this based on a KUB, flat and erect. And it's an ileus of the colon. So the small bowel is going to be normal, but the large bowel is going to be all distended. And this differs from a large bowel obstruction because there's no distal area that's good. The ileocecal valve keeps the small bowel normal, but Ogilvy syndrome makes this whole thing big. And the way you treat it is going to be decompression, so rectal tube, a stigmine, if you have the rectal tube in place and the rectal tube has failed, and ultimately they may need a colonoscopy to rule out the cancer. All right, in the first half of this lecture, we talked about chest pain, altered mental status, decreased urinary output, and abdominal distension. The focus I want to place is on delirium tremens, recognizing at 48 to 72 hours the person who's sweaty and diaphoretic with a headache and confusion needs benzos. And on urinary output, where you want to check for obstructive uropathy first, either post-op ileus of the bladder or simply King-Foley. For abdominal distension, focus on the difference between ileus, early after surgery, whole bowel affected, versus obstruction, that ileus just didn't get better despite doing everything right. And oh, by the way, there's an absence of gas pattern, but obviously a transition point, and Ogilvie's syndrome, which is going to have a big dilated colon in an elderly patient. The only one you need to operate on is the obstruction, so you might want to do an additional study like a CT scan with oral contrast to ensure you have a transition point. Let's pause for a minute and head over to the back half of this lecture. Let's finish off the back half of this lecture, postoperative complications, by talking first about some wounds. You might get two things with your wound. You might get dehiscence, or you might get evisceration. Dehiscence isn't that bad. It is a failure of the fascia. The wound is not open, but underneath, the fascial planes aren't closed well. So what the person's going to end up with, after everything heals, is a hernia. This is how you get a ventral hernia. It happens often. What you're going to see on the patient is a serosanguinous drainage. And it's going to be salmon colored. You might be able to feel the loss of integrity of the abdominal wall. The diagnosis is clinical. And the treatment is going to involve preventing this from turning into an evisceration. So you're going to use binders, reduce straining, so no lifting. And this is actually why you tell people who've had abdominal surgeries not to lift anything or strain themselves, because they might compromise the abdominal wall. And eventually you're going to need to reoperate. But you can do so electively to close that ventral hernia. This, of course, puts them at risk for having strangulation and incarceration, but it's not a big deal. You don't have to fix it right away. That's very different from evisceration, where it's not just a failure of the fascia, it's a failure of the whole wound. The skin breaks down and the fascia beneath. And what you get is loops of bowel popping out. So literally, there'll be loops of bowel hanging out of a hole, and you just expose the entire peritoneum to the outside. That's not good. That's a surgical emergency. The diagnosis is clinical, and you notice that by having the loops of bowel hanging out. And the way this happens is you either have physical therapy or a medical student have the person stand up prematurely, or they begin to strain way too soon. They do that, they end up with loops of bowel out of their body. The treatment is going to be back to the operating room. And that is emergently. But you want to prevent that gut from dying, from drying out. So in the meantime, the best next step once you identify evisceration is to apply warm saline dressings. Keep everything moist, but also keep everything out of the peritoneum. Never push it back in. What you've done is taken all that exposed bowel that's drying out and dying, all that exposed bowel that has bacteria on it, and reintroducing it into the peritoneum, which will require mass amounts of washouts to eventually get. Whereas if you just apply warm saline dressings and rush them to the operating room, you might forego the need for future procedures. And lastly, what can happen with your wound is a fistula. Fistulas are epithelialized tracts between one thing and another. And when we're talking about general surgery, what we're talking about is a connection from the gut, that is entero, to something else. Enterocutaneous to the skin, enterovesicular to the bladder. It can go anywhere. And when you think of fistula, what I want you to think of is fetid. The things that cause fistulas to form, the thing you have to address in order to get it to go away. F stands for foreign body. You left something in there, oops. E is epithelialization. This is what happens when you wait. T is for tumor. And I use for irradiation, inflamed, or inflammatory bowel. This is what happens in Crohn's disease. You get fistulas. And finally, D is distal obstruction. So the fistulas aren't hard to find. Stool will be interacting in different areas. Like they'll be passing gas from their urethra or passing dark-colored urine that looks like stool. Or stool will be coming out on their skin. So most often it's a clinical diagnosis. And the treatment is to simply remove or resect the fistula. But it may not be enough to resect the fistula, because if you've got another thing, a cause there, well, reconnecting it is just going to create another fistula. So what you may need to do is actually do a diversion into an ostomy, fix the thing that's causing the fistula to form in the first place, and then reconnect. Talked about a lot in this lecture. It's not a short one, but each of these is on its own mini topic that only takes about 2 to 3 minutes to cover. So this one is sort of a cram right before the test, because you're going to have to know a little bit of details about each thing, but these are stuff that actually come up post-operative complications. And that is post-operative complications.